Hi everyone, welcome to our fourth episode in our WENS podcast series. My name is Tanya, one of the new academic clinical fellows in ENT in Birmingham. I'm also the foundation trainee rep for WENS UK.
And I'm Ravina. I'm a current ENT registrar in North Thames, and I'm also the treasurer of WENS UK. This podcast came about because Tanya and I had been chatting quite extensively about our training and our experiences over COVID. And we were both at quite different stages, Tanya having been a recent foundation doctor and I had just finished my core training. And it was just so interesting to hear about the different experiences we've had. We just thought that we should make a podcast.
This podcast will be in two parts. The first part will be us talking to three trainers, and the second part will be us talking to three trainees at different stages. And hopefully throughout the podcast, we'll be able to share with you guys what we found interesting, as well as what we found challenging regarding surgical training.
So we've invited three trainers today who are central to the delivery of our training across the country, as well as trainees, as Tanya said, whom we'll hear from in part two. So today we're joined by three wonderful consultants, Miss Ann-Louise McDermott, Mr. Taran Tatla, and Mr. Shomit Ghosh. And I'm going to hand over to them to introduce themselves.
My name's Ann-Louise McDermott. I'm a consultant paediatric ENT surgeon at Birmingham Children's Hospital. I've been there now coming on for 20 years. I've been AES there for 15 of those years. I was very glad to hand that over to my young dynamic colleagues. I've been on the SAC for the last 6 years in total, and I'm SAC chair for the last year. I also sit on the JCIE Edinburgh College representative for the JCIE exams, and have been involved in national selection and for many years.
Thank you for inviting me to this podcast. My name is Taran Tatla. I'm a ENT head and neck surgeon working at London North West University Healthcare. I've been a consultant there for 14 years. I'm a training program director for North Thames Deanery, ENT high surgical training. I've been doing that for the last 4 years. I'm also a researcher, clinical research lead for our local CRN. I've been doing that for the last 10 years.
Hi, I'm Shomit Ghosh. I'm a ENT consultant up in what is now known as the Northern Care Alliance, which is in Greater Manchester. I was a head and neck consultant. I'm now transitioned into a rhinologist and facial plastic surgeon. I'm also the CPD for North West England, and myself and Taran sit on NAPDENT, which is the National Association of Programme Directors in ENT, and I've just taken over as the chair from T. So basically, I'm the admin of our WhatsApp group. That's how important I am nowadays.
So I wanted to start off the podcast by talking about COVID. That's, been something that's really been affecting trainees in the last couple of years. And on social media, we've been reading a lot about trainees' experiences during COVID, but actually little about what it's been like as trainers and your perspectives on how it's been during the pandemic, managing the trainees in the region, the delivery of their training.
So from my own personal perspective in Birmingham, working in a paediatric setting, we were quite unique and we were like a little island in a sea of chaos because we were not affected to the same extent as all the hospitals that were taking adult patients. So we were affected in the sense that we accepted paediatric patients from all over the region because we were doing it to free up space in the peripheral hospitals to allow them to deal with COVID. For those who worked within our institution, those trainees who stayed with us, they got a lot of paediatric operative experience and were protected from what happened to everybody else. And that, I think, is the nature of working in a tertiary paediatric centre. But we know with my SAC hat on that actually ENT was disproportionately hit because of the amount of benign and otology, rhinology work. And we still are a long way from getting back to pre-COVID levels.
Yeah, I suppose from my point of view, COVID is still going on in some way. So obviously Ann-Louise has just talked about COVID recovery, but I remember the first day when we went into lockdown, our biggest impact, which I suppose we needed, was on teaching programs, because across the board there was the directive from NHS England and the government that basically all training programs essentially were to cease in the way that training was delivered. All the juniors, all the doctors may be retasked and repurposed. So actually the next day after the training program, we were meant to have our training day, and obviously it was going to be cancelled. The week before that, I'd been on an England hockey coaching lecture course, which we'd done on something called Zoom. So on the day when we went into lockdown, our biggest thing from the Northwest was actually continuing training to allow people to have that social contact. So I downloaded the Zoom account for £9.99 as it was at that time, and we started. And that was the kind of the origins of the NapDent lecture series, which we then really took on with the AOT. And Taran and all my other TPD colleagues were hugely involved at the start of that. So I suppose that's my perspective from the curriculum support and social support side that we started at the beginning.
NapDent was such a fantastic initiative, and it really brought trainees from across the country together. And especially from my perspective as a new registrar at that time, we definitely were feeling that we were going to miss out on meeting each other in person, but this definitely allowed us to continue with our extracurricular education. So it was really great. And I think now we all probably have a bit of Zoom fatigue and are raring to get back to face teaching days. So hopefully we can do that soon.
It has led to a great resource, though, hasn't it? The lectures that you put together are just an absolutely phenomenal source of information and training. The latest update across all the specialty from people who do their various bits. I think it's a huge resource and was absolutely brilliant.
I think this is the thing. It's a proper national effort. Actually, one of the biggest focus of it was the AOT coming in. I remember people like Manny George and Freddie Green and lots of the other colleagues on the AOT. Because when we were talking about it one night, again, one of those Zoom conversations, I'll say, look, I'm doing my kettlebells and my recipes. That's everyone was cooking. So look, these are the podcast, these are the YouTube influencers. And you trainees went, yeah, we can do that. And then suddenly Bart's came on all the other training days. Ann-Louise talked. And one thing to say now, the AOT website has over nearly 5,000 subscribers and more than 250,000 views. So as a legacy, by trainees and inspired by everyone's, it's just phenomenal.
I was just going to say Baco was very similar, wasn't it? When Baco was forced to go online, again, what an amazing educational resource was produced that you could then download at your leisure for many months afterwards.
And Mr. Tatla, London was obviously really harshly affected by COVID. How did you navigate that with your trainees?
So being a head and neck surgeon, obviously services needed to continue. On the head and neck side, I personally found that I was still delivering care. The 2-week risk calculator was brought in quite quickly across a number of the trusts. And I know a number of our trainees were doing telephone clinics. That had some challenges because normally we're in the room next door to our trainee, observing them. If they needed to speak to us, they could bring a patient's history across. We could even meet the patient, examine the patient together. So actually having trainees remotely consulting, making decisions about patients, as a trainer, some apprehension about that. But we had no choice. This was thrust upon us. And we've learnt lessons, certainly with the data that we've collected, a very interesting exercise in digital. The theme continued beyond actually the way that we were delivering Zoom training actually on the wards. Trainees were, in my particular hospital, using endoscopes and were able to send information to seniors, to other colleagues, to help progress the care of our patients, to inquire of their trainers how they may manage a patient. So although the trainers may not necessarily have been in acute settings with COVID patients in A&E or on ICU, they were certainly allowed access to that environment through digital means. So yeah, digital has been a theme, I think, and it is to stay with us as a consequence of COVID for training and supervision and how we go about delivering the care that we do. London as a whole, in northwest London, I was at Norfolk Park. We were one of the first trusts that were affected and impacted when COVID hit. And as a big hospital, we cover multiple sites. We're probably not as well resourced as some of the teaching hospitals are. When your ICU beds so rapidly fill, when your workforce is so readily exhausted, introduces challenges. So actually getting individuals trained to do things that they're not routinely doing. And the teamwork that came about from other healthcare professionals being seconded into roles, frontline roles, patient-facing roles in the ICU and other places, really interesting lessons that came out of that, how we do work as in teams in under normal circumstances. But COVID really brought out a different level of teamwork and upskilling of various staff members, some of our trainees had to do things that they wouldn't normally routinely do. And I got to know many trainees that wouldn't have been on the head and neck firms just through tracheostomy rotors, dealing with the sort of airway interventions and managing patients, that were presenting to us.
I think just one final thing to add before going on to how kind of COVID has affected us now, right at the beginning. It caused a lot of these innovations. And obviously cancer care was affected. Ann-Louise with paediatrics wasn't as much affected. Because how their working style was. For my kind of thing, because I'm not a cancer surgeon, but I'm supporting that, was the emergency care of patients and how it caused innovation. So it went back to all the trainees and us going, well, what are safe ways of treating emergencies? And one legacy is actually, probably we may have been overcautious before COVID. We may have been, and now new ways of safely managing patients in an ambulatory basis, I think, is practice which has transformed across the country.
I suppose on a positive, with my JLO hat on, I've never seen so many papers. So for many trainees, I'm sure it's really helped pad out their portfolio.
And the amount of guidelines that have been published during this time for managing in the acute care setting patients, but also elective setting, it's been phenomenal. I think everyone felt that they had something to contribute and did do, even if they couldn't be on the front line, if they were shielding. Many of our trainees were pregnant, were working very hard behind the scenes, either doing telephone clinics or working on guidelines which were so useful for others that were working hard in the hospital setting.
I think from my point of view, I was in ITU for 4 months during COVID, and I remember thinking how odd it was that I was learning how to do a percutaneous tracheostomy before a surgical one. But nevertheless, I think we all learnt new skills that otherwise we probably wouldn't have, and there was a lot of shared learning. So what do you feel now that they really want to make up for, and what do you feel has really impacted them, and how can we improve things?
If I give you a little bit of background, which is quite interesting, the JCST analysed the figures across all the surgical specialties, and ENT was very badly hit because of the non-head and neck ENT, rhinology and otology. And it is still significantly affected. In some parts of the country, ear surgery's hardly restarted. And we're not back to anywhere near where we were. The emergency levels stayed the same. But what is interesting now, when the JCST analyse their data and they look at our ENT trainees over the last 2 years and they look at their ARCP outcomes, our ENT trainees are still getting outcome 1s and are going on to get their outcome 6s. So although we are standing up as a specialty nationally and saying we've been very badly hit by COVID, what's really quite amazing is to see how the efforts of everybody across the regions been quite innovative in how they do it. Trainees are still coming through. I suspect they may feel less confident than they would have done had they have not had an extra 18 months, 2 years of training. But on paper, as far as JCST are concerned, ENT outcomes don't really show how badly we've been hit.
During COVID, trainers and trainees have not had the same interactions that they would have had prior to COVID. ENT being such a social specialty, it's always been considered a friendly specialty. I think it's because of those interactions that you have as a trainee with your registrars, with your consultants. COVID took those face-to-face interactions away, certainly. And I think for a good 2 years, even post-COVID now, as numbers have come down, we've not had the same interactions re-established. The pastoral care that a trainer would want to deliver as a TPD, what I would want to deliver for a big region, geographically, it's been difficult. During COVID, we have in London had some breakthroughs, however, with being able to break down geographical boundaries for delivering care. As a cancer surgeon, I've been working across 3 or 4 different hospitals that I wouldn't have normally worked at, meeting the trainees that are allocated to those units, taking my own trainee along. So trainee passports have come about and training has been facilitated, certainly overnight almost, where previously people were told they couldn't do this without getting HR clearance. All of that disappeared overnight, and that's a good thing. Trainees being able to come into the private sector for operations that are being delivered in the private sector, again, a great thing. Why was it so difficult before? Why is it now being made difficult again? as we come out of the sort of COVID numbers that we had. Yeah, those are my reflections of COVID and as we come through into recovery, good and bad.
I think going back to, again, the start of COVID reflections, it's interesting what Taran's saying about ARCPs. I think there is a big regional difference in how different Let-Bs have approached COVID recovery. So, for example, in the Northwest, we've always done interim ARCPs and we're funded for it. And we do that we do it on Zoom and we use it as a formative process for the trainees. And we've always done that as a conversation. And as a result, the ARCP runs well over time. So it's interesting to see amongst our colleagues who's doing what. Ann-Louise has discussed at the SAC about our outcomes, which I'm sure she'll bring on further about our 10.1s. But one of the big impacted groups at the beginning of COVID were people who needed to shield, whether for any reason, any healthcare reason, or one of the big things is obviously pregnancy. Now, we're in the Northwest, we're 66% women, which is absolutely fantastic and shows the diversity of our group. But at the beginning of COVID, when all the government advice came in about who should be doing what, I sent a big message on our WhatsApp group. Within the first hour, I was suddenly the bearer of everybody's secrets, of everybody who was pregnant. And at first I thought everyone was trying to just ring me up. And by this third female to ring me up, I thought they're not just ringing for a chat. Go on, tell me. And the problem is, right at the beginning of COVID, these people had to shield. But what happened then, an impact on their training, was they were removed from clinical areas. And depending on how hospitals sorted it, people were then doing clinics or QI, whereas their colleagues were in tracheostomies, acute care, things like that. And right, even up to now, after 28 weeks, the guidance has gone and everywhere's a bit different, but people are losing operative opportunities. The problem with that is we did not want to be bad to anyone, so we gave people outcomes. Yes, you can progress. You haven't missed out. You're early on in your training. You will make it up in the 5-6 years or the 3-4 years. What I've just noticed now at the ARCPs we've done on Friday, we've progressed people at outcome 1, but they have had so much clinic and no theatre. Their other experiences, now we know numbers are indicative, it's about competencies, but they've missed out a lot. But they became the workhorses of the hospital. And as a result, what we're doing in the Northwest is we're adjusting people's learning agreements. Here's going to cause a bit of controversy. I'm saying to trainers, don't give people 4 clinics, 4 lists. How about give them 6 lists, 2 clinics, for a period of time that makes up for the time that they were disadvantaged? There's a bit of scandal for you. And let's see what the trainers say. I'll hand over to Ann-Louise.
I think that's actually great because post-COVID, it's all about innovative ways of trying to help trainees get back on track. So all that guidance from JCST of 4 and 3 and all those not doubling up in theatres, you have to be innovative. You have to do what you have to do now to get trainees to get that experience. And I know a few years ago, it was a real no-no to have a fellow and a registrar in the same theatre list every week. Now, provided that there's a lot of learning opportunities for both, and we just have to embrace this and think about it differently. And if doing more surgery for those people who've had shielding telephone clinics for 2 years is the way to go, that's fantastic. And one of my worries, and one of the worries that seems to be coming out, is that whilst people are finishing their training and going on to get their outcome 6, many of them do feel very underconfident. And one of the issues that has worried me slightly, speaking to some trainees who have finished, when they've applied for consultant jobs, the trusts are under enormous pressure to clear a backlog and COVID recovery. So certainly I can think of one trainee from another region who spoke to me to say that they went for an interview or they looked around at an otology job and they were hoping to have a bit of mentorship when they started their new consultant job. But the pressure to clear the 52 weeks of ear surgery that was backing up, that the trust really felt they needed somebody who could hit the ground running. And that's really worrying when our trainees are coming out having had 2 years with less operative experience than ever. And that's even if they have a fellowship, they're still behind what they would have done if they hadn't have got COVID. So I do think that if we are going to put our trainees out and they're going to come through with outcome 1s and then an outcome 6, some sort of mentorship going into consultancy is really more important now than ever, I think.
Yeah. Over time, they've done their bit. I mean, I think it's interesting with the new curriculum, it's competency-based training. How do you make up for the different experiences? You know, Taran with head and neck, a lot of the trainees will have had a lot of head and neck experience, but I've noticed massively, as Ann-Louise said, otology, rhinology, breadth of experience across the curriculum, we've lost. And we need to train the people for the future, for the next 5 years. So how do we return that? How do people feel about it? I think some trainees go, I just want to finish. I've done my time, not realizing there's a little bit more experience to be gained. Just before I hand over to someone else, it's like the thing about 1,600 operations or 1,800 versus 2,000 operations. It's not that you can't get good 100 tonsils versus 50 or 100 fezzes, simple fezzes. I'm a rhinologist. Simple anterior fezzes, as is Ann-Louise, versus 50. It's that breadth of experience. It's that 50 more times you've been in theatre. It's that 50 more opportunities or 100 more opportunities for things to go wrong and you to get that innate experience in managing the situation. And yeah, COVID has lost that. And how do we become innovative in simulation and other skills to upskill people quicker?
I was just saying, I think you're absolutely spot on there. But my only concern is that I would be worried that people will start unbundling one operation to try and push those numbers forward. And actually, that was never the aim. The only person that they're cheating or deluding is themselves by doing it. And do you think there's many trainees that just want to get finished now? I think training is so valuable. I personally would not be rushing to come out of it. In fact, I would be one of those trainees asking for a 10.1 and then a 10.2 if it was appropriate, to try and get the most I could out of training.
I think it depends on the individual. And I think the problem is some of the people who don't want to rush are absolutely fine now. We talk about confidence and imposter syndrome, and rightly or wrongly, we attribute it to a certain gender more than the other one. Hey, I'm here to be shot down. But some people want to finish, or some people have actually got a clear plan and go, do you know, if I can do this, I can get a fellowship or I can go to that. Or they're lucky enough to go to a unit where they're going to get a consultant job and get that mentorship. So life can carry on, because it isn't just finishing the training, it's getting on with the next phase of your life. So all I've got is anecdote. I have zero evidence. There's the people who want more. There's the people who want to finish. And I think we need to counsel people better in our new way of training, which all of us as educators are, and led by the SAC, and go, it's not a numbers-based game. It's an experience and feeling comfortable. Interestingly, with the people coming back from long periods off, I was speaking to one of my trainees just before, saying, I'm coming on this podcast. She's an excellent trainee. We've just appointed her as a colleague. But she came back from maternity leave in ST8. And the impact that she was on at the beginning of COVID, so essentially 2 years out of clinical practice, doing work but not. And then the case of Dr. Bawagaba, hugely influential on people's confidence of coming back. And it's how do we go, yeah, we support you in your decision making. Because that case wasn't about ability, was it? That case was all about support.
It's this mentoring again, isn't it?
It is.
We really do need to look at that. But having support for new consultants is more important than ever now.
I think you're so right. I think it is so important, especially at those critical progression points for mentoring and for support. Do you think initiatives such as a buddy system, a senior reg and junior reg who help each other, is that a good idea? What other initiatives could be implemented in the various deaneries to offer support and mentoring to trainees?
I think buddying is a really good system, provided you're buddied with somebody that you get on with. It could equally be a disaster. But I think anything like that would be great. I do know some regions are doing just that, where they have fellows taking senior regs and junior regs under their wing. I know that there's some talk about moving trainees around the region to try and buddy up. So instead of having a year in one unit, you might do 6 months and swap over to broaden your experience. And as Taran and Shom said, it's down to the TPD and the higher surgical training committees, how they want to really move their trainees to give them the very best exposure to what they need.
I think it's the service provision versus training age-old debate, which I think is just so difficult. And I think COVID has made it even more difficult Because whilst I think numbers, as you say, is important and we need that to progress, equally, if you have, perhaps I'm speaking as a new registrar, having 7 or 8 cases on a list, that means you do less as well, just because you have to finish the list. So I think it is quite difficult to get that balance right.
And I think post-COVID, and I don't know, Tara and Sean, what you think, but I find getting cases done in theatre was so much slower, was so much less efficient. We can't turn over the caseload that we used to.
I just wanted to say at that point, it's opportune. These new pilot surgical hubs for low complexity, high volume cases are a real opportunity for us to try and get it right. There's a lot of catch up needed, and there are opportunities where we could learn from what did work well with crossing between units, working across different hospitals, trainees moving from one place to another, TPD speaking to each other to allow trainees to cross even from one program to another to take advantage of opportunities that were being presented. I think that really is an innovation that we could use to our advantage and maximize a new way of delivering efficiency and quality in care. We've never had them. We'll have lots of reasons why we shouldn't go away from the comfort of what we're used to, but real opportunity for doing things different. That will bring numbers up for trainees. We'll need to work around how we organize ourselves so that opportunity is presented to all trainees. Some units we know have recovered way quicker than others. They've got back to almost, well, even beyond what they had as their original operating capacity and efficiency. What have they done right in order to do that? It's worth us just reflecting a little bit on those units. How did they organize themselves? How did they restructure and change things? We know other units have struggled. Why are they struggling? What are the local factors? What are the factors more regionally as change is happening? We need to be reflective of that. I think most trainees, in my experience, will seek training and will get trained. Most of them will recognize, have insight that they need support, whether it's from peers or from seniors. We've always had, when I was a trainee as a registrar, we had senior registrars that we looked up to who were informally mentoring us, and we would go to them with questions and we felt comfortable in a safe space. And I think as trainees come through now, it's having insight and recognizing that you do need to reach out to people, maybe others who have had similar experiences to you. If you're struggling as a trainee who's pregnant, who's going out of program and you're already short on numbers, thinking a little bit about others who may have been in a similar situation who may be able to guide and support. Maybe thinking about the trainers who have offered to provide mentorship and support, taking them up on it, and others who have had other difficulties. We know that a lot of relationships have suffered during COVID. We're not in a bubble. We go back to our families, we go back to our children, our partners, and people have had other difficulties that they've carried through with the difficulties of training, and have had the need for extra support when we took away the ability to provide support so readily and easily from them. I think it's those trainers who we know are training for the right reasons, who really are keen for their trainees to get the most from training experience, actually just putting in a little bit more effort, continuing to put in an effort, because now more than at any other time that they are needed and their skills are needed as trainers to mentor and support.
Thank you, Mr. Tatla. Okay, Mr. Gosher, do you want to say anything?
Yeah, just very briefly, it's that geographical variation that Taran's just picked up on. And I'll be a little bit controversial. Yes, we can put all the mechanisms under the sun for trying to change hospitals and stuff like that. People have to grasp the opportunities in front of them. And also, you tend to have a lead employer, which means you can work at any hospital in your region. It depends on how your region works. If you know that your mate is going off on annual leave in 6 weeks' time, take those opportunities. Get everything that's in front of you. Recovery, again, my controversial hat, everyone will slap me down, is not just about what's laid in front of you. It's the opportunities that you take. And I know everyone's come a little bit low energy off the COVID, and there's a lot of feeling of this has been done to us. Absolutely. Now, what are we going to do as individuals, as regions, as organisations, and as larger hospitals? But a lot of it is at the individual drive. Apologies. But there we go. Move on to national selection.
Yes, Mr. Tatla.
Can I just say one thing on this
Of
topic?
course.
It's just, again, opportunities that have existed and continue now. I've had a number of trainees that have joined me in the community settings where I run community clinics. We know that training happens in different environments. And as long as you're declaring it on your Form R, if you're doing work outside of your programmed and recorded work for your trust, if you are being supported by trainers in an alternative environment and you're getting to meet with patients and it's supervised and it's safe, then, that's another opportunity that exists. And we know that third-party providers that are well-structured, that have good governance arrangements, are able to, at this point in time, take advantage, innovate, and provide services at the doorstep of patients where patients can't get into hospitals. And so why shouldn't trainees be a part of that opportunity, be there, being able to help patients, but also be able to learn in that environment? So locally, we bring through patients from our community clinics into the hospital, patients who won't get a look in for many months because of our waiting times. They're getting seen in the community with consultants who are doing community clinics, and they're getting supported in the same way they would be in the hospital setting. And they're getting to meet patients and then list them and even operate on them when they come through into the hospital.
Thank you. Tanya?
Yeah, so I'll take over and talk about national selection and workforce planning. As we all know, national selection is some sort of hurdle that most trainees have to go through at some point of their training, and also is a very widely spoken about topic among trainees, off and online. We would like to have trainers' perspective from this topic. There have been quite a lot of new changes in the SC3 national selection in terms of portfolio as well as interview structure. Just for trainees to understand, what was the rationale and how did you come up with these changes, and was it very difficult? Could I direct this question to Ms. McDermott?
Yeah, thanks very much. I expected this to come up. With COVID, obviously the standard national selection process where we used to go to Hull and meet everybody face to face has gone. So initially, the first round, there was a lot of self-assessment and then validation from the consultants who would normally be involved with national selection. And we at that time were hoping that when COVID finished, in inverted commas, or improved, we would be able to return to our national selection model. However, the medical and dental recruitment services are very happy with the virtual format, and it's very well embedded. We have protested very robustly to them that we would like to go back to face, but they are refusing. And in fact, they've refused again just this week, actually, and they have refused. So virtual is here to stay. So the virtual national selection that was first devised was drawn up very quickly. It had to be put together very quickly, and it was never thought that it was going to be long term. So we've lost the clinical skills station and we lost the communication stations, and the way we looked at portfolio was all very different. So if national selection is to remain virtual, which is what it looks like it's going to be, we have to somehow make the stations more discriminating, because you don't get the non-verbal clues and the communication skill non-verbal clues that you would get sitting opposite somebody. So how do we as trainers assess trainees, and how do trainees put themselves across and show that they have all the prerequisites that we're looking for? So it's very difficult to come up with a solution quickly. This year, we introduced the communication skills. They came back online with actors. And actually, looking at the feedback from national selection, which we've only had very recently, it seems that by and large, trainees were very happy with that and they felt it worked well. It was the paper that caused a lot of upset. And if we haven't got a clinical skills station back, assessing a paper and looking at a paper is a well-validated form of exam. It's used at medical students. It's used by many other specialties. And the marking for it, there was very few marks really for assessing and looking at the paper. So a lot of people were very concerned that they're not researchers. They want to be hands-on clinical surgeons, and this was inappropriate. But actually what this is about is, can somebody read a paper, bearing in mind they had 2 weeks to discuss it with anybody they wanted to, but to be able to judge that paper and be able to relate it to their practice and how it would affect them. And that is a skill we all must have as surgeons, not just ENT surgeons, all of us. So we thought that was a good way of doing it. And I think a lot of people were very scared that they were going to be asked statistical analysis. And it is about being able to read and look at a paper in a clinical way and be able to judge it and relate it to your practice. And there are certain things that do need to change. For example, other things about national selection. So there's lots of things that can be improved. And we as a committee are looking at changing all of this to bring it more in line. So it's not just about the station with the paper, it's about the whole process. And we have to move forward in the mindset that this is going to remain virtual.
Yeah, I agree with you in terms of ensuring that people are informed earlier in advance. I think this year we had the notice for changing of the interview 2 weeks before the interview actually took place, and that caused quite a lot of upset. So I think that might be something we could look into in the future. Can I get Mr. Gosh to share his opinions as well, please?
Again, I think, Tanya, the thing with national selection or any selection is it's a competitive process. And there has always been competitive processes to get into medical schools, get into CT. The issue with national selection is we only have so many jobs per year. Okay. That's what comes back to the workforce planning question that you asked. Last year, not many. This year, quite a lot more jobs. Remember, there's appointable people, and then there is the people who score within the top 50, however you want it. So these things have to become competitive, and all the stations need to discriminate, as Ann-Louise said. What I noticed this year in our region, several of our trainees as core trainees did not get jobs last year, and their ranking was very poor. Okay? I say poor, it wasn't. They're all appointable, 30, 40, all excellent people. This year, with a more experience and more directed learning, not just hunting the portfolio, absolutely, but getting to do ENT in clinics especially, not just theatres. I want everyone to get to to clinics, making those decisions, active ward round management. Suddenly their scoring was transformed. And our guys went from ranking in the 30s and the 40s to ranking in the top 20. So I feel for people when they say, oh, we were only given 2 weeks notice. But that's because there's been a proliferation over the many years of courses and people going, this is what national selection is. Even though often we don't know what national selection is a year in advance because of the changes that are enforced on the likes of Ann-Louise and Charlie Hall, who heads up national selection. They have to be very responsive. And I'm just an examiner. I have very little to do with national selection, apart from turning up. So I'm speaking as an advocate of these aspects. So for everybody for national selection is do the ENT, look at the stuff, but the biggest discriminator is going to be in that interview. And the more polished you are, the more points you will get. That is the discriminator, not necessarily the papers and the posters and the things like that, which do count, but do the ENT. Ann-Louise.
Yeah, I think that's absolutely right, Shom. And I think, going back to this point about how long you're in ENT, it causes so much distress and upset. But actually, the few points, even if we didn't change the length of time, if we don't get to change that, the points you lose, if you've used your time in ENT properly, you can more than compensate from that in the other parts of the assessment. So it's not all bad. I think it gets a very bad press. And I think the old national selection where you went through your face-to-face communications, you went through your clinical skills, this year, the candidates all, without the vast majority, prefer this to stay online. It's the examiners who want to go back face-to-face. There are very few trainees who want to go back to a face-to-face national selection. And in many ways, in inverted commas, not having those practical stations takes away another element of stress about the exam. So we will have to think carefully about what would be a good discriminator station to put into that. And it's not just national selection. The same sort of problems occur with the Part 3 exam. Going back to face, there will be no paediatric vivas when we go back face to face. So what do you do? What can you do to help with your discrimination between the candidates? I wish I had an answer. It's something that requires a lot of discussion and a lot of thought. And we'll do our best to make sure we try and get it out on time and make it as smooth as possible.
Thank you. That's very useful to know from a trainer's perspective, because obviously when we talk among ourselves as trainees, it's quite hard to understand the fuller picture. Ravina?
Having gone through national selection the year before last, I thought I had quite a positive experience going through it. The part I found probably hardest was in my year, we had to deliver a 3-minute presentation on a topic that you were given a couple of weeks before, which was fine, but as in the notice, it was more that I felt, how do you make yourself different in that particular part? And I wonder if that's why maybe the station was changed. I'm not sure.
Absolutely.
I was really unsure how to make myself stand out in that particular part of the interview.
You're absolutely right, Ravina. It was incredibly difficult. Most people scored the same on that. It wasn't in any way a discriminatory station, or wasn't as discriminatory as we thought it would be.
Thank you. Mr. Tatla, do you have anything to share with us on this topic?
So workforce planning, of course, there's those that enter into programs. Looking at the other end, those who actually make it through a program and come out the other end. I've had some concerns that we're losing trainees, and trainees, very good trainees, who actually decide that they want a career outside of surgery. We've had a number of trainees who were initially academic ACFs and went through ACL and then actually decided that they were going to enter into pharma, medtech, and whether it's salaries or whether it's lifestyle, whether it's just the draw of not having to deal with the problems that go with everyday working in the NHS. We've lost talent, and that's sad. Seeing our training programs, we've had run-through trainees come through. I've been a big fan of run-through trainees, having not known how it would go. I have to say, in North London, we would have 2 run-throughs every year. They have been exceptional, and all of the hesitation that existed, in my eyes, disappeared. I know others are very anti-run-through. I don't know what Shom's experience up Northwest. I think it was positive as well, was it, Shom?
So the run-through trainees we have are fantastic. They are exceptional individuals. They're driven. They're performing really highly. My problem with run-through training is it takes away the opportunity for core trainees. It's all about competition. So for a couple of years in a lot of deaneries, you cannot fill. So you have your core trainees, but your run-through trainees are projected to take your jobs. So therefore, what is the point of core training? So either you all come in on the same system or you don't. And my thing was, it was North London, it was Yorkshire, it was Northwest that took run-through trainees. Other places didn't. So we were blocked. Okay? That's my issue. The quality of the run-through trainees, fantastic individuals, right? That's not my issue with run-through training. Ann-Louise?
Yeah, I think we're a small specialty, so we had a few problems, only a few minor problems with run-through, and I totally agree. I think we could have made it work in our specialty. There were a couple of regions where they found themselves unable to appoint at ST3 because the run-throughs were blocking places. But across the broader surgical specialty, it caused carnage having a mixed workforce. Bigger specialties, they had rota gaps. They had specialised training for those on run-through. Those on core were the lost. They'd come through what was it called? The lost tribe. They had no training in core. And it caused a lot of upset and a lot of inequality and a lot of rota gaps. So as a specialty, I think we probably could have overcome it in ENT, but across the whole surgical community, it just wasn't going to work. With the exception of neurosurgery, who've been allowed to continue with their run-through. But they are a unique group of surgeons.
Thank you very much. I was going to touch on run-through training, but since we are here, I think it's important to get an understanding of run-through training. I believe that it was started about 3 years ago and it ran for 3 years and it stopped last year or this year specifically. Can you share with us the reason why it was started and any other reason why it was stopped apart from the fact that it was creating 2-tier types of trainees?
It was stopped not just because of 2 tiers, but it was causing massive rota gaps. They couldn't appoint into posts. So, for example, in the Southwest, my understanding in general surgery, the rotas in general surgery, urology were completely unsafe because there were so many gaps. So it just wasn't sustainable. I think the same happened up in, I think it might have been Yorkshire way. Again, it was mainly general surgery were very vocal about it caused huge problems.
I'm just saying that there's a difference between our run-through and the IST, which are general surgery. And again, all those issues it's caused, which are those unintended consequences. Coming back to the question why it started, every 10 years we try to reform surgical training. House officer, SHO, F1, F2, potentially go back to 1F1, let's call it a house officer. So if you look at the time it takes in training for medical school to become a consultant in this country, it's about 10 years, give or take. The new curriculum may shorten it down. So the run-through training scheme, like in radiology and stuff, come out of F2, enter a training program. But we did not shorten down training just because you were in run-through. You still did your 8 years, ST1 to ST8. So the whole point of run-through was to try and shorten down the time it takes to being on the specialist register. To a degree and enter early, multifactorial. Do I think we can shorten training? I personally think we can do with attendant opportunities and workforce planning. But that's a bigger thing than just introducing a run-through grade.
Oh, we did have run-through trainees in Birmingham a number of years ago. Certainly I worked with 3 and they were amazing. We had them, must have been, 10 years or so ago, and it worked really well. And then they pulled the plug on it again then. We just go round in circles.
Yeah, two of my colleagues who have been, I was a year 6 registrar, so an ST8 in new money, and we had run through for 1 year, modernising medical careers, and it was abandoned after 1 year at that time. So that's 2008, 2009.
Yeah. Thank you very much for that. If we can touch on the aspect of workforce planning, you actually mentioned a question that quite a lot of us are thinking, actually, what is the point of core surgical training? We've seen a lot of conversation on social media as well as offline about not having enough ST3 numbers and the competition for core surgical training actually getting higher and higher every single year. We obviously have been really in a very privileged position, but unfortunately, we haven't really seen a lot of good reviews of core surgical training. I don't know whether Ravina can share a bit of her experience in core surgical training before we start the questions.
I think overall, my core surgical training experience, when I look back on it in hindsight, was actually very positive. But I remember just always worrying that I wasn't operating enough. And actually, that's not what helped me to get my number at all. But I remember really fixating on that. But I'm talking from a place of privilege that I was able to pass my exams. And I think from perhaps a TPD perspective, I was a trainee who didn't really require any extra help or anything. But in my mind, I was always a bit worried about my operative abilities and going into ST3, would I be good enough when I'm a day 1 registrar? I think that was where I feel core surgical training could be boosted. But I do understand the flip side of that is that there are other things to achieve during core surgical training. It's not just about the specialty you want to do. It's about acquiring broader surgical skills. And I definitely did that because I did 6 months of orthopedics. I did 6 months of general surgery, and all of those things I think have really helped me. And so overall, I think my core surgical training was excellent.
Thank you for that, Ravina. I just wonder if you guys can share with us your thought on the question of what is the purpose of core surgical training, considering the worries of trainees and considering there's quite a lot of people will not get ST3 numbers.
So if I just start on this one, the core surgical training, I totally agree with you. It's been very hit and miss depending on where you trained, what region you were in and what units you got put in. There is a lot of work underway at the moment to completely reform core surgical training. And in fact, it's top secret and completely embargoed, and they'll shoot me if I share it. But all I can tell you is that the changes look incredibly positive, with a year 1, which will be pluripotential. So the GMC want people to be able to train and be able to choose and swap into any surgical discipline of their choice. And then year 2 will be very themed in the specialty that you want to go into, so that you will be registrar ready at the end of your second core surgical training year. So the purpose of core surgical training, whilst I fully agree with you, it's not really been looked after at all in recent years. Going forward, it's going to see some major reforms and really make it fit for purpose so that you come through without your worries that Ravina had of have I done the work? It will be regulated in inverted commas with what sorts of things you should be achieving and giving you an idea of where everybody should be by the end of it. And that's the theory.
Yep. Thank you. That's very encouraging to hear. Yep. Carry on. Yeah.
I think from Ann-Louise, what core surgical training really delivers is a very well administered, structured path in the start of your training. Okay. However, in coming back to your question about workforce planning, why do it if there's no ST3 numbers and things like that? It goes back to my thing about workforce planning. How many surgeons of each type do we need? Yeah. And that goes for any job, not just us in medicine. But remember, there's also many routes to get to your end target, whether you want to be on the specialist register or you want whatever career path you want to do, how you want to work, doing, let's call it ENT because we're on that podcast. You can get there in many ways. So one of the things I hear from my trainees about core surgical training is they might not get the rotation they want, or they might have to move house and geography, which are very real things. I think we can be creative. I don't know if I'm allowed to say, but lots of hospitals set up little training schemes in their hospitals and give equivalence certificates, much like the CSER pathway in higher surgical training. What core surgical training does, and it does need to be redesigned, is be fit for purpose to give you your basics to move onwards. It seems to be a very London thing going into pharma and finance and stuff like that. I haven't really seen it in the Northwest, but how do you equip people to move along their career? And remember, if you don't get an ST3 number, there are many other ways of getting to the end in supported units and mentorship and recording your outcomes and things like that.
Mr. Tatla.
Yeah, to some extent, we should celebrate as well when trainees do go on to these alternative paths. They are real opportunities that are presenting, which didn't exist before. Ophthalmology is a specialty that really has embraced it. And there are a few other specialties that actually have invited pharma medtech, that sort of marriage inquiry during your training years where you're linking up with companies, doing research with them, developing other skills. I think some of these trainees that have left have even come back and brought back their networks, their connections that allow us to think about innovative new projects and doing things differently. I think it's not necessarily a bad thing. It's just about numbers. How do we plan ahead? How do we take away training that isn't fit for purpose or training that was wasted, time that was wasted? If you've got good trainers, if you've got good trainees, I think you can bring them through in a limited number of years and bring them out of a training program to be good surgeons. And that's what the run-through training system, when it works well, could do. We've lost the opportunity to do that in those places that were keen to make it work. We've now got a group that we hope in a few years' time we're going to have a better system for, but it's hit and miss. It really depends on what rotation and what mentorship, what support you get, how some trainees we know, even from medical student days, they're preparing their CVs to optimize themselves for that number that they want in a specialty of their choice. And that's great. The more informed you are, the more networked you are, the easier you're going to find it. But there is a group that are still just doing the jobs and they're wasting time and they're not getting the support from trainers that they should have got. And unfortunately, they won't get into the specialties of their choice. They'll choose a specialty that maybe wasn't of their choice, or they'll wander along and many go into general practice because they think I wasn't good enough or something wasn't there for me. And that's sad. I think T is an exciting specialty. We've not had the undergraduate focus for our specialty in previous years. We're trying to pull that back. We have dynamic trainers, but dynamic trainees already in the specialty. And we should be readily attracting those core trainees and facilitating their passage. I don't think you need to spend 3 years in those basic surgical training posts, 4 years in order to demonstrate your allegiance or competence in ENT, in order to satisfy your trainers that actually you're committed to the specialty, that you're not going to drop out, that you won't decide 2 years in that actually it was a wrong choice that you made. I don't think that. I think some trainees have a good idea what ENT is from medical student days now, and certainly foundation years. We've got some great programs for foundation trainees. They're getting some good exposure on the wards and they're attracted to the specialty. We just got to carry on moving forward. Ann-Louise.
I was just going to have just a quick word on workforce. You quite rightly say about, why apply if there's no jobs to go into. The bottom line is HEE has a set amount of money. And whether we like it or not, we are a small specialty. And whilst we feel we are in crisis, we don't feel it, we know we're in crisis job-wise. As far as HE are concerned, there are specialties in more need than us. And at the moment, they are very focused on cancer care and mental health. Okay, they're the big people's plan, that's where the money is aimed. So this year, they did give 10 new numbers to ENT, and they said that they chose the distribution based on the population demographics. We were in no way involved in any of the discussions, so some regions got them, some didn't, but that's what we were told. What we don't know is whether they will continue, whether those numbers will be available next year and the year after and the year after, or if it's just one cycle. And I don't think HEE know themselves at the minute because it's all about money. So some specialties have no problems. They are training too many consultants. So neurosurgery, if you qualify as a neurosurgery consultant, there's no jobs to go into. So, I did volunteer to take some of their numbers to ENT, but they were having none of it. So it is difficult to know how many jobs we'll have going forward. But we do know our specialty is, at the moment, when I was a consultant, you couldn't get a job. There were too many of us and no jobs to go into, and you had to sit in locum posts until somebody moved on. Now there are over 120 empty consultant posts in the UK and Scotland and Wales and Ireland as we speak that are either filled with nobody, or they have a locum in, or they have people in who are not on the specialist register and they can't train. So we really do have a long-term workforce problem in ENT. And I think for trainees, knowing that, I think if there's a unit you like, you really want the consultants in that unit to start maybe pre-planning. I'm not joking. I think now with so few trainees, that trainees need to shine. And if there's a unit that you want to go to, you need to really make sure that unit know that you are dynamic, ticking all the boxes, and you want a job there so they can plan, because there's not enough ENT trainees out there. So that's a top tip for everyone coming through. Make sure you highlight to the ones you want to work with just how fantastic you are in advance.
But it comes back to exactly what Ann-Louise has said there. Okay, so training isn't just get your thing and then see where it is. 6-year interview, build those relationships. You have a set number of numbers per region. So we have 43 numbers in the Northwest. 6-7 years ago, you came in your number, you were out of there in 6 years. It was very easy for us to predict every year 8 numbers. Now we have LTFT working for 3 categories, okay, OOP and things like that. So when in the old days, when people went out on OOP, the number was basically on suspension. You did not appoint to the empty slot. That's where LATs came in and things like that. We don't have that anymore. So it's on us to be creative, to keep a workforce going. You can say, I've got 43 numbers in circulation at any one time. When people are on OOP, when people are on unpaid maternity leave, the funding is still there. So with clever planning, you can still appoint numbers. Okay. And this is something we're all learning as we go on, because our workforce is changing rapidly. Because if we just allowed myself to say go off 80% on 60%, I'm not giving my number up for 4 more years. Tanya, you cannot have my number. I've got it.
That just brings me on. You may be aware that HE are running a pilot on less than full-time training, and this is going to make workforce planning even harder. In the past, you had to have the various categories, like category 1, you had to have a disability or something that would allow you to work part-time, or category 2, something unique, or maybe you had a baby, but now category 3 is you can go part-time for any reason of your choice, and you don't have to tell Shom or Taran or me or anyone why you're doing it. And it's entirely up to you. And if you want to work during that time, or you want to do whatever you want to do, it's going to make life very difficult, I think, on the shop floor for all the TPDs and for us as a specialty to be able to workforce plan with that degree of flexibility. And I know it's supposed to increase morale and increase work-time balance, but the practicalities of running a training scheme with people on that sort of just going out for an indefinite length of time like this. The pilot comes to an end, I think it's August of this year. Is that right, Sean?
I think so, yeah. It started in a lot of specialties before in anaesthetics. It came to us in February, and we'll see. And it's 80%. I think what everyone's doing leadership modules and things like that, which is brilliant. Stick with your TPD when they're drawing up the rotation for the next year. See the angst that causes when give their choices and trusts go, why are you sending me 2 people on less than full time? The town goes, I'm a cancer surgeon. Who's going to retract for me when I do that wonderful neck dissection? Who am I going to demonstrate that IJV to if they're not here on that 20%? It really does cause not just service issues, but remember the logjam onto your colleagues. So if I go off, which is my right, someone's got to pick up that on-call work, all those indeterminate things that happen through the week. This is our next challenge. We have to make it work, but this is our next challenge. But everyone should be aware of the consequences.
I think you've just hit the nail on the head. We have no wiggle room in ENT. We do not have enough staff and enough bodies in the units and trainees to be able to mop up all that extra time out without the burden falling on other people. Now, I say burden, that's fantastic, operative, clinical, on-call experience. Got to look on the positive side of picking up the extra work. But it is a problem. And something we'll have to wait and see how that will pan out.
Thank you very much for sharing the insight to workforce planning and how things, were decided, because it's very helpful for trainees to understand how should we provide support and mentorship for CT2 or core surgical training year 2 who might not get the numbers they want, because that is a critical career point for a lot of people. And we're hoping that core surgical training will change for the better in the next couple of years or so. But the reality is there will be a lot of people who will not get a job, and how we should go about supporting them, and any tips and advice from you as trainers.
I think the odds of getting a number are better than they ever were for core trainees. I think if you go for national selection now, the probability of getting a number is quite high. There was a period in time where, as an SHO, it was a lottery. I think, yes, those CT2s that are struggling, you've got to ask, what didn't I do in order to score the marks? When it came to national selection, where have I lost marks? Hopefully you're thinking well in advance and you're starting to build your points for the portfolio from medical student days, if you're really interested in ENT, but certainly foundation year, if you've had the opportunity of doing some ENT, those audits, those points all count. Getting a poster presented, getting a presentation done, being active, going and letting people know that you want to do this, because it may not necessarily present to you. You saying, no, I'm going to go find my trainers and explain to them that I want a presentation on this. Not only do I want to do the audit, I want to present it, and I want to go for a national meeting. And I think if you take that approach, your CT1 year will be productive, your foundation year will be productive, and you would have done all the right things so that you scored the points coming into CT2, and you'll be on a winner. You'll get a number. Those who don't do that, who haven't done that and haven't forethought and haven't sought support, are the ones that are scoring lower and are missing out on the 1 in 2 chance that you have of getting a number if you go forward to national selection. That's what it was, I think, this year, was it?
Yeah, it's so true. I think planning ahead is so key. I think a lot of the points from my experience that I got from my national selection I got them in F2 and F1 and F2 posters and things like that, because actually probably leaving it to CT2 is late. And coming back to the medical school point, do you feel like it's fair that there are points for things achieved in medical school? Because I'm actually not sure how many medical students know about those points and that they'll affect you in 5 years' time. And when you apply, you obviously can't go back in time to that particular section. Everything else you may be able to compensate for. But I remember thinking that when I was doing my national selection, is that fair?
I think it's very fair. This is what we want. We want keen, dynamic, focused. They don't have to have written an ENT paper, but they have to have shown that they will go the extra mile and they will do something different. So I think those medical students who have actually done papers and presentations, I think good on them. For me, that's a real star in the making for somebody to have forethought it and have put that extra work in on top of all those exams that have come through medical school, and they're thinking outside the box and doing more work. I think it's great. So yes, I do. And I think SFO is a great way of just letting people know, and I know they're very keen on telling medical students how great it is to do papers and presentations. And you may find, Sean, Taran, in our region, we have an MIO, Midland Institute of Otolaryngology, the regional meetings. And we get flooded with medical students presenting papers, winning prizes for doing essays, the undergraduate essay prize. This is all really good stuff. So I think it's great.
Absolutely. We have the best regional society in the north of England, ENT Society, in direct competition with the MIO. But
we're joining you next
year. Yeah, absolutely. We're joining together next year as siblings. But the surgery or all these competitive are competitive specialties based on communication and initiative. So whatever level you start taking, that is really important. Ravina's thing saying about the deadline for application, interesting, is not the deadline for application. You need to be competitive 6 months beforehand, taking into account processing times for publication, poster presentations, planning the meetings. Look at ENT Audiology News. Where are the meetings? That count. Don't just make one up with you and your mates, but just that count. The other thing is, here's a little tip. If you're going to publish and a registrar says, I've got a really good paper, PubMed them. Look at their CV. If they've never published before this time, they're not going to publish with you. Go to enthusiastic trainers. Yeah. I'm proud of about 2 papers I wrote before I was in SHO. Probably proud of one I did as a registrar. That's what took me onto my consultant job. In my registrar job, that paper took me 3 years to write. And not because I was late with lots of other papers, but that one was 3 years of work. And the communication and initiative, that's a sign of a good surgeon, isn't it? Because that's all about teamwork. So if you're finding a really willing ST3 or an ACF as a CT1, that is a sure sign that someone's going to seek out best opinions and help and innovate in their surgical practice. These are guidance for your career development. It's just that we assess it earlier.
Yeah, I just wanted to echo those points. Last year, we set up the Ravina Ryan Awards in 2015 in London, really to celebrate what trainees were doing across the different ranks. And last year, when the Ravina Ryan Awards went national through ENT UK under their umbrella, and they continue now part of the academic foundation for ENT UK, we had a medical student that won one of those awards. And it was fantastic to see that effort and that innovation coming through and being presented, the confidence. And you want more of that. We want to see it in our core trainees. We want to see it in our foundation year trainees. We want to see it in our medical students. That is the future. It's so exciting to see someone do such a fantastic presentation that's relevant. And it can be part of your elective. It could be part of your special study module. It could be your extracurricular stuff because you've just decided that ENT is a dynamic specialty and you want to be part of it. And you've got role models. You've got a great structure that you see in WENTS. You've got a great structure that you see in SFO, where the specialty says, no, we're relevant for you. We may not have been there in the undergraduate curriculum, but we want to be, and we want you guys to know about us. And I think I'd encourage as many medical students as possible to go for the Ravina Ryan Awards this year because they're there for the taking. And then they go on your CV. They're the points that you'll score for national selection, right? When you get those presentations, those acknowledgements to put on your CV.
A different story, but I've nearly left medicine twice to go take job offers outside of medicine, once as a registrar and once as a consultant. Good job offers. So it does not have to be in ENT. Show some leadership, education, pharma companies, things like that. Things that show your ability as an individual. Yeah. Doesn't have to be the audit of nasal packs and antibiotics and should they stay in there for 24 hours.
Yeah, I was just going to say my advice for any medical students that come through our unit is to look at all the different regions, at things like the Ravina Ryan. All the regions offer prizes that are up for grabs for medical students. And lots of these ENT UK has an undergraduate essay as well, doesn't it, Taran? So it is there for the taking.
Thank you so much. My last question is, what do you think is next for ENT?
We, in our department, were 9 consultants and 6 consultants and all men in our 40s. We've just appointed 4 new consultants, 3 of whom are women, mothers, phenomenal individuals. They will bring a different dynamism to our department and how we practice surgery and how we think about things. Okay, but if this is like, you look at who's coming through medicine, through undergraduate, the postgraduate route, the diversity of background. I think for ENT, which was a very traditional specialty, which has changed immeasurably over the last 10, 15 years, honestly has. And my job wouldn't have existed, the amount of people as a rhinologist, facial plastic surgeon 10 years ago. There's a few people, a few pioneers in every region, and now there are trainers everywhere. And you look at this, look at paediatrics. So I think that's the exciting thing, is the diversity of the people coming through and the diversity of thought. That is what's going to shape us and ahead of a lot of the other surgical specialties getting.
And I agree. We are moving into new types of surgery, and again, COVID has in some ways helped this. And certainly in my practice, the eye is very much, outside the globe is very much our domain now. And I think we need to be grabbing this with both hands and running with it. I think it's very exciting where we can go with ENT. Certainly in my own life in paediatrics. So for me, it's eye, nose and throat, not ear, nose and throat. So that's just a personal one. But I think as a specialty, we've got a lot more women coming through, which is wonderful. I think it will change how we work. And with the new curriculum, I think once we all settle in and we bed in and we understand how to use it, we will bring out the best in people and bring out better trainees.
Yeah, Ms. Tatla.
Something that we've not touched on, but it's relevant to trainees, is EDI. I think ENT has been ahead of the curve when it comes to surgical specialties, and many surgical specialties colleges have looked at the example that ENT UK had. For example, our council in the last year, the mix of individuals, but also the approach that we've taken. Yes, there's more that we can be doing, and we should be getting the facts. We should be talking with knowledge about what actually happens when it comes to recruitment, what actually happens when it comes to seeing trainees complete their training and get appointed into consultant posts. I think ENT UK has been ahead of the curve, but more work to be done. I think the future with COVID bringing digital in, I think we're going to see grasp that and run with it. And I think the trainees, whether they're medical students or the younger trainees who are so digital literate, are going to be the champions for that. And we're going to see that quite clearly in the next few years with technology enhanced learning, with telemedicine, teletraining solutions, which is really quite exciting. You know, I've finished the textbook this last year, but I'm really keen to see it being translated into a digital tool for simulation and doing other things. I won't do that because I just don't have the know-how, but I know that the trainees who are coming through who see that world, VR and all the rest of it, are the ones who are going to grasp it and run with it. And they're going to do it not just at a local level, they're going to do it globally, because the world's just opened up with digital. So not only will you produce resources and materials that are going to be there for local trainees, but to help support the delivery of care and education in other parts of the world, which is even more exciting.
Thank you, Mr. Tatla, for ending the podcast on such a positive note. Certainly, I agree that the future of ENT is very bright. So, yeah, thank you so much. That was a very interesting discussion. So, Ravina, what do you think? Because obviously, there was a lot of challenges that was mentioned. There was a lot of new things that also were discussed that I didn't know about. So I was just wondering, what were your thoughts about the podcast, the whole process of hosting it?
I thought it was fantastic. I think we both learned so much from hosting this podcast. And this is only episode 1. There's so much more to come. We touched on so many important topics, such as training during COVID, national selection, workforce planning, and everyone was so candid. So thank you so much, Ms. McDermott, Mr. Tatla, and Mr. Ghosh. You were all fantastic. And I'm really looking forward to continuing this discussion on our next episode with the trainees.
Yeah, please tune in for the next episode in which we will discuss similar topics, but from trainees' perspective, from 3 different trainees at 3 different stages. And hopefully we'll learn a lot from the next episode as well. Thank you for listening.
As always, we invite you to contact us with any feedback you may have. Please email wentz@entuk.org, or you can follow us on social media to join our conversation. We'd also love it if you could leave a review with your podcast provider, and do share this episode with your networks. Thank you so much for listening.